Okay, so this lecture was about changes in ventilation, diffusion, as well as elimination in reference to the urinary system. So let's talk about changes in ventilation and diffusion first. So ventilation, this is just the movement of air in and out of the lungs. And then diffusion, this is the movement of oxygen and carbon dioxide across the respiratory membrane as well as cell membranes. So it's really a two-step process. We need to get oxygen from the alveoli into the blood, and then from the blood we need to get that oxygen into the cells. And then of course CO2 just goes the opposite direction. Perfusion, this is the process of supplying oxygen to the body, to the organs. And then respiration, this is using that oxygen to make enough energy to keep us alive. So this is just showing kind of the setup of the gas exchange structures in the lungs known as the alveoli. So these bundles of alveoli are known as alveolar sacs, and then kind of like a net that surrounds these alveolar sacs are these capillaries, and that's where the exchange of gases will occur in the lungs. So we talked about a brief overview of some of these structures. The big takeaway was the respiratory membrane, which I'll talk about again in a second. But basically, air is going to be conducted from the upper airways to the lower airways to these terminal portions known as alveoli, and that's where gas exchange will occur. So ventilation again, movement of air into and out of the lungs. It involves breathing in, which is known as inspiration, and breathing out, which is known as expiration. There are a bunch of players here that kind of modify ventilation, but basically breathing is a mostly passive process. It is initiated by the diaphragm as far as inspiration, and then expiration is normally passive process, and it's really mostly just changes in air pressure that drives the breathing process. But there are receptors in the lung that kind of sense the state of breathing and the function of the lungs. Chemoreceptors will detect changes in the gases like oxygen and CO2. Inspiration, that's the only way we obtain oxygen, of course, and then expiration is the way that we get rid of CO2. Okay, and CO2 is a waste product of metabolism. So diffusion, basically oxygen is trying to get into the body's cells so we can use it to make energy, and carbon dioxide is trying to get from the cells, out of the body. And the rate of diffusion of these gases will depend on a number of things. For example, it will depend on the pressure of the gases, the solubility of the gases. So oxygen is not as soluble as CO2, which we'll talk about in a second, as well as the thickness of the membrane. So if the membrane that these gases are trying to pass through is very thick, obviously the rate of diffusion will decrease. Also pH of blood and temperature, which we'll see. So when you see partial pressure, this basically just refers to the pressures of individual gases in a mixture of gases. Okay, so if, for example, air is a mixture of gases, and each gas that makes up this mixture will have a pressure that contributes to the overall pressure of the gas. Okay, so this is kind of a zoomed in section of an alveolar sac, and it's kind of just cut, okay? So we can look inside the alveoli. So in an alveolus, you'll have a macrophage, which obviously is important for infection and trying to control infection. We have the type 1 cells. These are the cells that will actually exchange gas with the blood. And then we have type 2 cells, which are these cells that produce surfactant. Surfactant is a detergent, and its job is to reduce surface tension within the alveolus. And that helps to keep these alveoli open, because we obviously want them open. Okay, and then they have zoomed in on the respiratory membrane. So the respiratory membrane, this is kind of the first place where oxygen gets into the blood, and this is also the last place where CO2 will enter the lungs and be exhaled. So the respiratory membrane is composed of these type 1 cells of the alveolus, the endothelial cells of the capillary, and a basement membrane that kind of joins them together. Okay, so this is where oxygen will get into the blood, and this is where CO2 will get back into the lungs. Okay, so let's talk about oxygen transport. So oxygen's not very soluble in water, so a very small percentage, about 1.5, will be found dissolved in plasma. So since it's not very soluble, we have a solution. and that solution is hemoglobin. So each hemoglobin protein pigment molecule will contain 4 iron atoms, and iron is what actually binds O2. So each iron can bind 1 molecule of O2. Okay, and then when all 4 iron atoms are carrying oxygen, it's said that hemoglobin is fully saturated. Okay, so let's talk about things that will affect. Okay, so let's talk about the factors that sort of influence how oxygen will move and the rate at which it moves. So the partial pressure of oxygen. So if you have a low pressure of oxygen in the tissues, hemoglobin will unload more oxygen into the tissues. That makes sense. Okay. Also the partial pressure of CO2. So if there are increases in the pressure of CO2, you're going to have more unloading of oxygen. That tells you, if CO2 is increasing, that tells you that there's increased metabolic demand, and therefore we need more oxygen. As temperature increases, oxygen unloading also increases, and then decreased pH will also result in more unloading. Again, that indicates to the body that there's increased metabolic demand. Okay, now carbon dioxide transport. Only about 7 to 10% of CO2 is dissolved in plasma, which is more soluble than oxygen, but still not very soluble. About 20% is actually bound to hemoglobin, but it's not bound to heme like oxygen is. It's bound to amino acid portions of hemoglobin. And then the majority of CO2 will enter red blood cells and undergo a reaction to form bicarbonate, okay, by this reaction down here. And of course that will be important for our intrinsic buffer systems within the blood, which I talked about here, but again, this isn't anything you need to worry about. So some general manifestations of impaired ventilation and diffusion. So obviously abnormal breathing patterns. Anything outside of apnea, which is normal breathing, can indicate pathology. Hypoventilation and hyperventilation. So hypoventilation can result in hypercapnia. Hypercapnia is basically increased CO2 in the blood. And then hyperventilation can result in hypocapnia. Hypocapnia is low CO2 in the blood. Okay. And of course, if you have increases in CO2, which would occur in hypercapnia, if this occurs enough, you could become acidotic, and hypocapnia, low CO2, that would cause an increase in blood pH, which would be alkalosis. Hypoxemia, this is reduced oxygen in arterial blood, which is different than hypoxia, which is reduced oxygen in cells. And the big giveaway there is emia. Emia refers to the blood. Then cyanosis, that's the bluish coloration or discoloration of the skin and mucous membranes in response to low oxygen or poor perfusion. So a cough is a reflex. It's a protective mechanism for our body to try to rid the airways of something bad. There aren't many of these in the distal airways and the alveoli, so if things get really deep, it might not be sensed very well by these reflex or these receptors in the lungs. So of course, changes in sputum, hemoptysis, if somebody's coughing up blood or bloody sputum, that can indicate a pulmonary problem. And then dyspnea, which is that feeling of shortness of breath, and orthopnea, which is basically shortness of breath while lying down. You see that a lot with heart failure. Okay, then we started talking about the diseases, starting with pneumonia. So pneumonia, of course, is an infectious disease. Can be community acquired or nosocomial. And basically you have vast inflammation of the bronchioles, alveoli, and then some of the interstitial tissue as well. So it can basically be caused by any pathogen. It can be caused by bacteria, virus, fungi, parasites, protozoa, the list goes on. But bacteria is really kind of the one most people care about. It's very common, and it can cause a pretty severe disease. So it's spread by aerosol droplets, so the aerosol route, but it can also be aspirated into the lungs. So some common bacteria that cause pneumonia: Streptococcus pneumoniae, which about 30% of people are colonized with. Therefore, they may aspirate that into the lungs, and that can kind of kickstart pneumonia. Some other ones, things like Haemophilus influenzae, can cause pneumonia, and a bunch of viruses. And there, almost anything it seems like can about cause pneumonia. Staph aureus in some cases can cause pneumonia. Pseudomonas aeruginosa can cause pneumonia. But the most common cause, at least in adults, is Streptococcus pneumoniae, or pneumococcal pneumonia. You may hear it called that as well. So, a little bit of the pathophysiology. Immune cells like neutrophils, since we're really talking about bacterial pneumonia, neutrophils will come in. They will try to consume the bacteria, and once they do, they will die, and that will basically form that pussy exudate. And then, as immune cells continue to infiltrate in, and also fibrin will be laid down to try to, prevent spread. This will manifest as consolidation, which is basically just kind of this mass of immune cells and fibrin that you see on a chest x-ray. Okay. So clinical manifestations: fever, chills, productive cough, fatigue, dyspnea, crackles when you listen, pleuritic pain, which is kind of that sharp stabbing pain. So a number of clinical manifestations for pneumonia. Diagnosis and treatment: so history, physical exam, CBC is very important. Obviously, chest x-rays, and then obtaining sputum samples and identifying what the cause is. And then, of course, treatment: treat with appropriate antibiotics. Macrolides are a common class of antibiotics used here. An example of that is azithromycin. And then, of course, any other supportive therapies. Okay, COPD. So this is typically a progressive disease, just characterized by persistent limitation of the flow of air. And most common chronic lung disease in the world, and most commonly caused by inhalation of cigarette smoke. So a lot of times you'll hear this described as a combination of chronic bronchitis and emphysema, also a combination of chronic bronchitis, emphysema, and asthma. But the book mentions that each of these diseases by themselves can be considered COPD. So we're going to kind of talk about them separately, starting with chronic bronchitis. So this is just showing that typically with COPD, you have really not a huge issue getting air into the alveoli, but when you try to exhale, that's where the problem happens, and air kind of spins around in here and it can't quite get out. Okay, so chronic bronchitis, the definition is hypersecretion of mucus in a productive cough for at least 3 months per year for at least 2 consecutive years. So obviously, inhalation of irritants like cigarette smoke increases inflammatory response, as well as the production of thick mucus. And a lot of times with chronic smoking, you destroy that mucociliary elevator because of the metaplasia of those pseudostratified columnar cells. And of course, if you don't have that cilia to push mucus up, it just kind of settles. And then emphysema, what happens in emphysema is you have basically a permanent enlargement of the alveolar sacs. And that's because the walls between the alveoli are destroyed, and all of those alveoli just kind of coalesce into one big, giant, stiff superalveolus. Also, there's elastin that wraps around the alveoli, which helps to give the lung elasticity and compliance. However, elastin is broken down in emphysema. Cigarette smoke is notoriously just tragic on elastin. That's why you see so many, you can see it in the skin of somebody that's been smoking 20, 30 years, because that elastin has just been pretty much destroyed. So here is a normal alveolar sac. You can see all of these nice walls between the alveoli. This helps to increase the surface area for gas exchange, but in emphysema, these walls break down. Okay, so you really lose lots and lots of surface area. So asthma, of course, chronic inflammatory disorder, which is basically kind of a combination of hyperresponsiveness of the bronchi, mucus production, and of course, with all of that, you have airway constriction. Clinical manifestation: dyspnea, wheezing's a big one, coughing, tachypnea. Asthma is actually a really common cause of chronic coughs. As far as treatment, beta agonists like albuterol, so that's like a rescue inhaler, inhaled corticosteroids, so that's more of a long-term type solution, and then anti-inflammatories like antihistamines and anti-leukotriene agents, things like Singulair and all of your other antihistamines like Allegra and Benadryl and things like that. So you can see down here, you have smooth muscle constriction. I mentioned in class, whenever smooth muscle is irritated, it's going to constrict. So that's kind of the problem here. You have this irritated smooth muscle, it constricts. You have mucus plugs that form because of the excess mucus production. So really a nasty, nasty thing. And it can obviously be a very serious condition in its acute state. Then we talked about cystic fibrosis, which is a genetic disease. It's autosomal recessive, and it's due to mutations in the CFTR gene. And there's a number of mutations that can cause cystic fibrosis and change the severity of cystic fibrosis. It affects a lot of the body, but it manifests mostly in the lungs. And basically, these people will have abnormally thick secretions, like mucus, which is the problem in the lungs. So basically, CFTR is a gene that encodes for a chloride conductance channel in the membranes, and mutations in this channel basically inhibit its function. So what happens is chloride cannot be transported across the cell membrane, and that's going to inhibit water transport. So if we look here, I must have drawn this on the board. Well, basically, Cl minus and Na plus and H2O, they are all always together. So if Cl cannot be pushed into or across the membrane, then sodium is not going to be pushed across the membrane, and water is not going to be pushed across the membrane. So that's why the mucus is very, very thick. Okay. Not only that, but you're also going to have sodium and water move into the cells more often. Okay. And that's, again, because chloride is kind of hanging out, inside the cell. So mucus plugs form as a result of more mucus production. And, of course, mucus is thick because of the lack of water. And since it's thick and kind of sticky, it adheres to the respiratory epithelium. This is a big precursor to infection. So manifestations, infections are common, chronic coughs, purulent sputum, tachypnea, wheezing, other respiratory manifestations, as well as systemic manifestations. So diagnosis, obviously any genetic testing, family history, history and physical exam, but also the sweat test. So the sweat test will actually indicate excessive amounts of chloride in the sweat. And of course treatment, trying to loosen that mucus, keep the airways clear of the mucus, treating any infections. Nutrition is very important, bronchodilation. Life expectancy is getting better, but it's still relatively low, somewhere between 30 to 40 years, and males actually live much longer than females affected with cystic fibrosis. Alright, then we talked briefly about the urinary system. So the functions of the urinary system, of course, regulation of body fluid and volume, and composition, elimination of waste, like nitrogenous waste, like urea and ammonia and things like that. Of course, hormones, the kidney is an important place for synthesis, activation, release of hormones like erythropoietin, renin, we know what renin does, vitamin D, it's activated in the kidneys, so really important for endocrine function. And then it's also, especially the kidneys, they are the long-term controllers of blood pressure. Manifestations indicating altered urinary elimination, so changes in urine, and any changes, pain, bleeding, nausea, vomiting, fever, of course, all of those indicate that something's going on. So just a brief overview of the urinary system. So 2 kidneys, urinary bladder connected by the ureters. If we open up the kidneys, we have the renal medullas, the renal medulla, which is composed of these renal pyramids. This is where the collecting ducts will be. Collecting ducts will drain the urine into the minor calyces, which are down here, and then the major calyces, which are these bigger ones. This is the renal pelvis, this is the ureter, and then down into the urinary bladder. So urine formation begins in the functional unit of the kidney, which is known as the nephron. The nephron is composed of 2 components. the glomerulus and the renal tubule. Okay, the renal tubule includes the proximal convoluted tubule, loop of Henle, and the distal convoluted tubule, and then the glomerulus is just basically a capillary, a very high pressure capillary bed that will push fluid into the renal tubule, as well as Bowman's capsule. Bowman's capsule is really the first portion of the renal tubule. Okay, so let's just walk through this really quickly. So here's the glomerulus. Blood comes in through an afferent arteriole. It pushes filtrate into Bowman's capsule. Bowman's capsule catches the filtrate, and then that filtrate will travel first through the proximal convoluted tubule, okay, then the loop of Henle, and then the distal convoluted tubule. And the whole time this is occurring, we have reabsorption and secretion, which we talked about in the fluid and electrolyte balance lecture. So I'm not going to go into detail about that again, but those are kind of the big takeaways. So basically, urine elimination, as the bladder fills with urine, stretch receptors stimulates contraction of the detrusor muscle, which is the smooth muscle of the urinary bladder. Okay, this is the parasympathetic function. The neck of the bladder relaxes. The internal urethral sphincter relaxes. Okay, this is not voluntary. Again, this is controlled by the autonomic nervous system. And then, the voluntary release of urine is accomplished by controlling the external urethral sphincter, which is obviously voluntary skeletal muscle, which is being shown here. So kidney stones. A kidney stone is also known as a calculus. The condition of having kidney stones is known as nephrolithiasis, sometimes also known as urolithiasis. And basically you have salts that crystallize and can cause urinary tract obstruction. Most stones are composed of calcium oxalate or calcium phosphate, but there are many other types like struvite and cysteine and uric acid stones. But calcium oxalate and calcium phosphate, those are the most common. More common in men. And what influences their formation? There are a number of things. Some risk factors, though, obviously being male, but also being between the ages of 24 to 49. Decreased fluid intake, poor diet, decreased level of activity, those are all risks. So the patho, formation related to the supersaturation of these salts in the urine, and what happens is these salts precipitate, meaning they start to solidify, and then they crystallize. So these salts, the precipitation of these salts come together, they crystallize, and that's what makes these stones. Again, some other risk here, genetic predisposition, so they tend to run in families, but it's not a genetic disease by any means. UTIs, kidney disease, diabetes, obesity, all risk factors. Clinical manifestations, renal colic, that's the big one. That's that flank pain. It may radiate. It may change as the stone moves. Nausea, vomiting, sometimes hematuria, depending on the size and the location of the stone. And then diagnosis, presentation, 24-hour urinalysis, imaging. So if it's large enough, you'll be able to see it pretty easily with a CT scan. Pain management, high fluid intake, potassium citrate, which is actually an inhibitor of some stones. And then if they're too large to pass, then they may be removed, or they may be broken up with a procedure like lithotripsy, where you take ultrasonic waves and break up large stones. It's just showing some of these different stones. And then we finished with polycystic kidney disease, which is really a genetic disease. I want you to think of this as a genetic disease, where you have these the growth of these cysts that are on the kidneys and within the kidneys, both kidneys. And basically, as these cysts continue to develop and you get more and more of these cysts, you lose functional kidney tissue. So you lose the nephrons, and that results in loss of function of the kidneys. So it may be inherited in an autosomal dominant or autosomal recessive pattern, autosomal dominant being the most common. Again, autosomal dominant means you only need to inherit one allele in order to have the disease. And obviously autosomal recessive, you need both alleles in order to develop the disease. So the patho, these cysts will increase in size, they increase in number, and as that occurs, you replace the parenchyma, or the functional tissue of the kidneys. There's pressure on the renal blood vessels, which is important, as we'll see in a second. But as this occurs, you decrease perfusion, you decrease tubular flow, And you can just see how this is kind of just a snowball effect, leading to eventual renal failure. So clinical manifestations, an important one here is hypertension. And that's because the pressure on the blood vessels actually stimulates the RAS system, the renin-angiotensin-aldosterone system. And we know that the job of that is to increase blood volume and increase blood pressure. So that's why you'll see hypertension. Flake pain, headaches, UTI, kidney stones, cysts of other organs. So sometimes they'll get cysts on other organs like the liver. And of course, impaired function of other organs develop as the condition worsens because you're affecting the kidneys. And the kidneys are obviously vital organs. So obviously, as their function decreases, you aren't effectively eliminating waste and things like that. Diagnosis, presence of 3 or more cysts, which you would find on ultrasound. A family history, of course. The presence of extrarenal cysts, that's also an important indicator. And then genetic testing, obviously, because this really is a genetic disease. Treatment, symptomatic care, any sort of lifestyle changes. And then supportive therapy during end-stage renal disease like hemodialysis and any other supportive therapies. So this is just showing, a polycystic kidney. So you'll see these cysts on the outside, but if you were to cut the kidney in cross-section, you would also see them inside. And you can just see how this would replace functional tissue. And these kidneys will typically be quite a bit larger than a normal kidney.